Ma'am,
Yes, dear.
I have a question.
Please ask. Assume that our female don't have any complications and she is fit for natural birthing. So when she's fit for the natural birthing and we already know that she don't have any issues, then we will start, our physiotherapy is going to change in after 34 weeks. Up to 34 weeks, we all understand that we were giving her pregnancy care, and there was a role of Kegel exercise, there was isometrics of adductors, glutes, strengthening of your quadriceps, everything was going on. But as soon as we know that our female is entered into 9th month and 34 weeks is completed, now we have to now change our physiotherapy. And we are gonna make her ready for the childbirth, easy childbirth. That is our role here, okay? Our aim is there. So when we're talking about that, we should understand what are the level of the full term and early term. So, like before giving her all these protocols, if the female is gonna deliver around 39 to 40 weeks, we call it as a full term birthing, a full term labor. When it is before that, it's like she started her labor at the time of 37 and 38 weeks. So she hasn't finished, she just finished 9th month, like 38 to 36 weeks. So as per the monthly calendar, she hasn't finished the 9th month. It's just a weeks she finished. So we will call it as a early term. So when she's delivering the baby into 9th month, so we are calling it as an early term. When she is delivering the baby before 9th month, she's delivering in 8th month. So we call it as a premature childbirth or preterm birthing. So it means term was not completed and there was some complication, and that's why baby is like the labor started, or we have to do the C-section or all these processes. So there can be premature childbirth or premature labor, or there might be early term birthing. When she complete this whole 9th month, then we are calling it as a full term. When she's she's beyond that 9th month, is 41 and 42 weeks is she's delivering, we are calling it as a late term. It's been already, it's the time is crossed and she is not started with the labor process. And if still she didn't started the labor process at the time of 42 weeks has passed, still the labor is not started, we are calling it as a post-term. So now how it is affecting a female? If the baby is coming before 37 weeks, or it means that in 8th month itself, so that particular time, it's not like baby can be always safe after 34 weeks, but still we always feel that baby should complete normally 38 weeks. Okay, but yeah, it can be safe in 36, 30, after 34, 34, 35, 36 also. But before 34, if the baby is coming out, so we are calling it a premature birthing. So in that case, there can be some complication which the baby can show you after the birthing. So something baby is not fit to come to the external world. So something which is going to affect the newborn, and some complications can be there, complication related to the respiratory system or other systems, immunity might not develop. So they might be, they are going to take the baby into incubator for certain period of time. They have to give the baby the environment which was important inside. And why this happened, there can be different factors behind that. Okay, so if the baby is coming in the 9th month, and so that's a good birthing actually. In this time, we know that 9th month is a good, we can feel the baby movement also, amniotic fluid is also there, baby can come outside, baby can survive outside, baby mother body was also supporting the baby. So things are good into this particular full term time period, in a 9th month time period. Once the mother is crossing 9th month, so after that we understand that baby is growing at a faster rate inside, And once baby is growing inside, all the space will be acquired by baby. And now amniotic fluid, the level of amniotic fluid can go down, and that can somewhere disturb the movement of the baby. Baby might be more bigger to roll around inside the uterus. So that can show less movement of the baby in a female. So she might feel that the baby movement is not that strong how much she was feeling before. So we understand that why the baby is not rolling, not able to roll from one side to another side. It's because of the big size and less amniotic fluid. And it's like, the swimming will be disturbed, swimming of the baby will be disturbed inside. And she might start getting dryness in the amniotic fluid will be less into quantity. Okay, so that can cause just a less movement. And once we are seeing, and it can also cause a lot of loading onto abdominal diaphragm. So this female can start getting a lot of issues like breathing issues, as well as she can start having the issues related to the pelvic floor. So because loading will be downwards around the cervical region, around the pelvic region, pelvic cavity. So she might give you those kind of symptoms, breathing issues. She might tell you a lot of back pain issues, too much of lordosis, anterior pelvic tilt, and the balance will be issue in a female. Stability will be also issue. Now we understand in 9th month, this pelvic rim is going to go for relaxing. That is also relaxing actually. And pelvic floor is also relaxing, and baby is shifting downwards. So loading is going on into the pelvic cavity. And the bone is unstable bone. So SI joint laxity is there, pubic symphysis laxity is there, widening is there, and round ligament pain, uterosacral ligament pain can be high in this case. So these can be some extra symptoms patient can tell you. And lack of movement, she will not able to feel the baby movement. And sometimes baby can stuck in one position, and the breech position also, that because of it's not able to move and rolling is not possible for the baby because of the lack of space, because size of the baby is big. So breech position, baby can acquire in 9th month. So this is what we have to help her in giving her different positions. And next can be this is like urine incontinence. More urine incontinence and more constipation can also be there. Now, physiotherapy is going to change after 34 weeks. Physiotherapy from 34 weeks, depending upon, as soon as the 34th week has finished throughout this whole pregnancy, now our rehab is going to shift. It's going to depend upon what is the expected mode of delivery or the childbirth. Is the baby female is fit for natural delivery, or there are some complication that she's not fit for natural delivery and she has to go for C-section. So according to that, we have to make her body ready for that particular things. If natural birthing is possible, no complication, we have to make her ready for labor and perineal relaxation. So this is what we will understand in today's session. If that she is not fit, it means the baby is going to come from the abdominal pathway. So we have to make her ready psychologically that how the C-section is why the C-section is important and it is required. So psychologically she should be ready for that, and we will also make her body also understand this. We will also give her some kind of guidelines that what is important for her and what will be the immediate complications. So we will also make her ready for that. So psychologically and postnatal immediate care, what is required, we will give her that kind of counselings. And in natural delivery, we have to relax the perineum because baby is going to come from this downward pathway. Baby is going to cross this pelvic bone, vagina, cervix, vagina, pelvic floor muscles, perineal tissues, and perineal skin. Baby will come outside. So this is one way. So we have to work onto the perineum. And all these structures will work onto the movement, so which can increase the pelvic space inside, which can help in moving the baby downwards, and will help her in all this complete opening up of the inlet, mid inlet, and like opening of outlet. Everything will make her ready with, and relaxation of the pelvic floor muscle also, and relaxation of the skin. But in case of C-section, the baby is not going to come out from there. So no, so there's no need of making her ready for the labor. So labor is only for the natural delivery and this childbirth when baby is coming from the vagina. And otherwise, like we will continue with the Kegel, we will continue with the strengthening exercise, quadriceps, isometrics for glutes, and isometrics of adductors, closing. So we don't have to open up the downward structure. So keep strengthening the lower perineal region. It includes everything, the main muscle, pelvic floor. So Kegel will be there. Continue with the Kegel, but in case of the natural delivery, we have to stop Kegel here, because Kegel means contraction. We don't have to increase the contraction of the muscles and try not to close the area. We have to open the area. So we will stop Kegel in natural delivery after 34 weeks, and we will keep continuing with the Kegel in case of C-section, if the baby is going to come out through the C-section. So Kegel will be continued, strengthening of the adductors will be continued, strengthening of the quadriceps will be continued, and glutes will be continued. So we can keep continuing with the core exercise, no problem at all. But core exercise and core strengthening, we have to stop in natural delivery. So according to that, we are going to change that we are going to shift our physiotherapy. Rehab. Every woman may have a completely different experience with each new labor and each delivery. So there's no fixed protocol. We have to do the protocol. We have to decide the exercises and the protocol according to individual. It should be tailor-made for every female. So now let's understand the first one. Let's not talk about the C-section first. Let's just understand about the first one. If the baby is coming out from the downward, it means labor is going to come into picture. Body is going to create those kind of change into the system, which is going to open up that pathways. So the hormones will come. So can we help something in the movement of the baby outside? According to the mode of the delivery, we have to make her ready. Our care and counseling matters for her. First focus should be on teaching her mind and body. Both, it should be relaxed, because she's entering into 9th month and hormone has a big role to play. So if she has any kind of anxiety going on unnecessarily, so try to counsel her a lot. So in 9th month, more focus will be into relaxation of mind and body. So give her education, lot of education, and make sure that your education, what words you are using, your selection of the words, terminology is very, very important. Your body language is very important. Do not make her anxious, more anxious or more fearful. She might have the fear going on in the brain that, oh, the labor will be painful, how I will cope up. But we have to make her ready with giving all these relaxation techniques and education, because a baby is gonna come and through this natural pathway, and what is the positive sides of this natural birthing, we will counsel her, will educate her. Same way, if the baby is coming out from the C-section, we will also give her the positive side of C-section. So there's always both the sides. So we'll try to focus on to that particular side, which is the baby is gonna come. So more positive side of that particular birthing. The first thing is relaxation of the mind. She should not be anxious. If she will be anxious, lot of thing is going on into the brain that is going to affect the hormones. And hormones is something which we really required. So we don't want our female to this anxious, and she should not have this kind of fearful situations. So meditation is something which we have to focus more, and we have to counsel her a lot about the meditation, whatever mantras, different type of relaxation of the brain, so relaxation therapies. So like we discussed on the pregnancy sessions, there are altogether 4 to 5 types of relaxation techniques which we can use during pregnancy. So same relaxation technique will be more focused into this particular time period. So we have to relax. We have to give her progressive muscle relaxation technique, yoga we can teach her, meditation we can teach her, and some kind of those kind of guided imaginary techniques we can teach her. So this is very, very important. Start breathing exercise. Breathing has an important role when baby is going to come out in both the things. It can be the C-section or in the normal delivery. Breathing is important, and we know that if the baby is going to come out through the normal delivery, so baby, we need an opening of the outlet. So in this case, breathing in is very, very important. Keep supplying the oxygen, enough oxygen to the uterus. So it doesn't matter what breathing, what type of technique you are giving to your patient, it should be comfortable breathing. So don't confuse your patient. It's according to what is suiting her, how, in which breathing she's feeling good. You can go for pursed breathing, which is always everyone's favorite during pregnancy. You can give her this kind of abdominal breathing, thoracic expansion, or pelvic breathing. So you can all depending up, like you can practice everything with your patient. So breathing is also very, very important. Modified perineal physio as per the mode of delivery. So these are the important, the girls who are with me who were with me into pregnancy, you understand these techniques, but still I will send you the video recording of that session where you can go through this respiratory role of the breathing during the pregnancy. I'll share you the videos so you can go through that. It is by Dr. Divita. So which she has taken a good session on that. And there's another exercise, another video where I explained about the relaxation techniques. So I will share that relaxation techniques with you. Autogenic training is there, progressive muscular relaxation is there, guided imaginary relaxations are there. So this is what we discussed on our pregnancy sessions. Now let's talk about the natural birthing. Our aim is making her perineum ready or making the perineum relax. So lower body stretching and pelvic floor muscle exercise for relaxation, opening up of the pelvic floor, stretching of the pelvic floor, relaxing of the pelvic floor is very, very important, because pelvic floor muscles is the floor where these canals are passing through. So if the vagina is passing, and around the vagina, we need all the muscles relaxed. We don't want any muscles to get tight. So pelvic floor relaxation is very, very important, and as well as the elasticity of the skin and tissue around the vagina, we also need that. So we don't want tight, adhesive, scarred, or tight tissues around the openings. If there will be adhesions or scarring or any kind of tight tissue, that is going to unnecessarily close the outlets, and it will make the delivery difficult, and there might be baby will stuck into the labor process, and it will delay the labor stage 2 when the baby is crossing that whole outlet. So keep making the how we can help in creating the relaxation. So perineal stretching and massaging is very, very important. Mind and body relaxation and breathing techniques are very important. Proper counseling for labor and position guidance are important. So let's understand that one by one. After 34 weeks. Now, before 34 weeks, we were not giving her any deeper squats, and we were not giving her stretching also, hip flexor stretching and all these positions. We were not giving her because we didn't wanted the weight of the baby to go downwards over the cervix. So, but now after 34 weeks, we can start pushing the baby, or moving the baby into the pelvic outlet, because relaxing hormone is creating the space into the pelvic bone by creating the relaxation of the pelvic bone and the ligaments which were supporting the pelvic bone. So they all are going to go for more lengthening, more loosening. So this is what connective tissue will start getting separated. So if this is going on inside, internal physiology is changing. So physiology is making us also, ready that we can now start moving the baby into the inlet. So in 34 weeks, if I'll show you, baby is going to shift more downwards, because if you understand, the uterus was progressing upward. Okay. So what happened into third month, normally into third trimester, actually, third trimester, bones start changing. So we have all these pubic symphysis. We have this ilium, and then we have a sacrum. Sorry, my drawing. Okay, so this was the bone. So what happens in the third trimester, and specifically after 34 weeks, when body is making it ready. So at that time, widening of sacrum is gonna start. Widening of pubic symphysis is gonna start, and widening of ilium is gonna start. So when they will start widening, they are gonna create more weight downwards. Okay, so let me explain you through this. We know this is the pelvic cavity, and we have this ilium on the side, and this is pubic symphysis anteriorly. These are the pelvic floor muscles, and we have coccyx and sacrum at the back posteriorly, and these are the two long iliums. Okay, so now up to second trimester, there was no effect on the bone, but in third trimester, bones start getting loosening and widening. And that will be more widening is going to happen into the after 34 weeks when baby will start moving down. So what happens here, baby was moving anterior upwards towards that xiphoid process, but after certain time when it will reach up to the xiphoid, now xiphoid we cannot move xiphoid upwards, so that will be stopping point for the baby, that no, this like we can't expand more than that. So but body is giving this development to the baby is developing. So at that time it cannot go up, now body has to create a change downwards, so downward shift is going to happen. So for that, whole pelvic bone will start widening, and this is what relaxing hormone is important. It will create a relaxation of this. More relaxation will start into after 34 weeks actually, and once it will, this is inlet. Can you see this one? This is inlet, and this is outlet. This one is outlet. The level of ischial spine is outlet. The level of this one, this whole rim, okay, is inlet. And the level of this one, we are having ischial spine here. So ischial spine here, ischial tuberosity outside, and this inlet level is here inside. So according to that, body is going to show you three different change. First, inlet will start opening. Okay, so that starts into this when the baby is developing in 8th month and 9th month. So once it is the inlet is opening up, now I'll show you through this model. You can see this is inlet. Okay, so now this is normal you, me, and our pelvic bone is like that. But during pregnancy, this third trimester, this pubic we have to increase the inlet. So for increasing the inlet like this, look, it's increasing the inlet like this. Okay, more space will be there. So when it is increasing the space, so we need, so that is going to create a laxity of this joint, SI joint. So more laxity is going to happen. Not only the laxity of the joint, first the bones are going to change. So this is a sacrum, and normally this is normal widening of the sacrum. So that will go for more widening. So it will be this whole diameter is going to increase on the sides. Okay, so this will widen everywhere. This sacrum is going to go for widening into third trimester. So once it will widen, same way, this ilium is also going to go for widening. So bone is changing. Bone consistency is changing inside. So this will also start widening, and this will widen. And same way, pubic symphysis, which is pubic bone, tubercles, right and left, they will also start creating a laxity inside the bone. So bone itself will widen up. And now not only the bone, tissues which is present, the ligament which is present inside. So this is a pubic symphysis. So this ligament will start getting broader. Okay, so that will be stretching of the ligament, and that is going to cause more. The beginning will also will already there into second trimester. This is what we are calling it as a pubic recti. So this will go for more separation, more widening of the pubic symphysis. So this will widen up, this will widen up, this will widen up, and they are going to create a laxity of there was a ligaments which was supporting here. Now, and assume that we were having like sacrospinal ligament posteriorly. So sacral spinal ligament will go for laxity. There will be inguinal ligament anterior, so which was coming from the ASIS to pubic symphysis. So there will be laxity of inguinal ligament also, because the bone is widening. So this ligament will change, lax ligament. SI joint, we have a supportive ligament, iliosacral ligament. So from sacrum to ilium, we have a ligament. So they will start getting widened up. So laxity will start into those ligament also, because bone is widening. Assume that the room where you are sitting right now, so the wall of this room will start widening. Okay, if they are widening up, so whatever is attached with the room, they will also start laxity, or they will also start getting loosening. So all the ligaments will start getting widened, and that is going to change somewhere that the joint, the space between, it's going to increase the space between the joints. So SI joint, two SI joint, right and left, they will start getting showing laxity. Okay, SI joint relaxation or pain, then will also be if the relaxation is going on, so instability will be the first thing, and pain can be the second thing. Okay, and if they are, the bone is changing into consistency, and that it is changing its diameter, so you understand that what was attached with the bone, not only the ligament, even the muscles were also attached. All the muscles from back, front, they all were attached. The core was attached. So whatever muscles were attached around the pubic symphysis and ilium, which was coming from the rib cage, anterior abdominals, they will go for more lengthening and more stretching, because this bone is changing its consistency. So anterior muscles will again show extra relaxation or extra laxity. Same way, posterior muscles will also get like more tighten, more we will say the strain actually, because anterior pelvic tilt will be more. So that is going to cause more lordosis. So that will unnecessarily put stretching over the all the back muscles. They will start getting tight. You can understand the iliopsoas will like all these muscles will start getting psoas major, psoas minor, iliacus. They all muscles will start getting tighten or strained, because the bone is shifting anteriorly because of the anterior pelvic tilt. So those muscles will get more tightening, and even the muscles which were around the back, around the sacrum region, will be also strained. And so this happens at the posterior side and anterior side, and that side ones over here. So patient can start showing you another issue over here is more widening. Okay, so more pubic flare. So pubic angle, which should be 90 degree, because of this widening, that might start showing, because pelvic floor is also going to stretch out. Okay, they will be more stretch out. So this angle will be more angle, space between both pubic rami. So let me, this is one pubic symphysis here, and pubic rami is going like this. So look, I'm touching both fingers like that. So the angle is always 90 degree normally, but this angle is going to change because of the laxity which is going on, and that will create a widening of the pubic angle. So we call it we start telling it as a pubic flare. So pubic is going for flare, and if you'll check that in third trimester, 7th month, 8th month, 9th month, more widening, more change into the angle you can always observe, because of the widening of the bone. And if the pelvic bone is changing, so you can understand if that is changing on the diameter, increasing the diameter, so that is going to pull oblique muscles from the top. So that oblique is attached with the ribs. So, and with the ilium here. So the obliques will be stretched out obliques on the sides. And now they will be stretched out. They will pull what? They will stretch the ribs on the sides. Straight. That is going to cause, again, that is going to add into the what we are saying is rib flare, the angle which is present between the ribs, sternal angle, that will also change. So these two angle will be widened, more widened into third trimester. And we'll check always. It will be like normally, if it was 90, it might show you 130, 120, more widening into rib angle as well as the pubic angle. So we call it as a rib flare, more rib flare and more pubic flare. So that comes into that particular time period. But this is a requirement of the body actually. And now this we are saying is sacrum. If you understand the sacrum here, so sacrum will start widening up. So this diameter will increase. So shortening of the sacrum will, you can see that the length will not change. It's just the width of the sacrum is going to change. Width of the ilium is going to change. Length will not change. So this width is going to give you more lax SI joint or SI joint pain. Okay, it's like this kind of laxity will be there. So instability is the first thing which will be there into the more instability into the 9th month or after 34 weeks. So female require some kind of support because all the pelvic bone is unstable bone. So she needs pelvic belts or pelvic supporters. Okay, stability belts starting from the SI and to the pubic symphysis. Or as a physios, we can apply kinesiotapings. So just to unnecessarily unload the this joints actually, maintain the stability. So this is a requirement of the body and we need that this thing is important. So baby can keep moving. So now it is widen up. So now baby can shift down. As soon as baby will shift downward, so automatically the pressure from the rib cage will the diaphragm will lower down. So female might don't have that much of breathing problem. Now baby shifted down. But as soon as the baby will shift down, what is present downward? We have bladder. So baby is gonna, this uterus is gonna put more loading over the bladder, and female, another issue will be more urine incontinence. Because of most uterus will not, bladder will not be able to expand. So female frequency of urination will be very high into 9th month because of this downward shift of the uterus. So this one thing will be very, very common, more frequency of urination, and that is going to put loading downward. So we can understand that relaxation of the pelvic floor will also come into picture. So pelvic floor goes like that. This is a pelvic floor and this is a pelvic floor. But if this whole bone is shifting, so you can see the levator ani, internal muscles, the internal layer of the pelvic floor, this is the levator ani. If you increase the diameter here, so levator and the ischial spine and this whole muscles which is attached, they're gonna expand. So levator ani relaxation and laxity begins. And levator ani is the muscle which maintains the tone of the pelvic floor. And if the levator ani will get affected, so it means the tone will not be maintained, and the tone around the organs. So the levator ani is for the support of the organs. Organs are resting here. So if this is the bladder, so bladder is resting onto this muscle, isn't it? Look like this. So this is for support. But if the support is loose and weak, so there will be more downward displacement of the organs. So that can cause a supportive dysfunctions during the 9th month, starting into the 3rd month itself, 3rd trimester itself, 8th month, then 9th month. Every female is different actually. So levator ani is going to go for stretching. And now this is a muscle which is present operator internus anteriorly. So there will be loosening of this muscle, which is coming from the lower limb, and then we have a piriformis at the back. So this piriform, all the anterior muscle will go for loading, and all the posterior muscle will go for tension. So this is piriformis, and this is the over here we have a piriformis into this foramen. So this piriformis will go for tightening. Okay, so posterior muscles will go for tightening, and anterior muscles will go for loosening. So this will be the continuation throughout the pregnancy until the time the childbirth is not going to happen. So the bone will relax as well as the pelvic floor will relax, and this is going to put displacement of the organs downward. It means the urethra will be downward, and female can also show you more urine incontinence. And whenever she will cough and she will laugh and cough and not jump, she will laugh and, for example, she's coughing and she's laughing or she's sneezing. That can, and now the pelvic floor is not strong around the canals. So because they lose their legs pelvic floor, they will not be able to maintain the continence, and female can also show you leakage problem. Okay, stress incontinence will be into the issue. So, but this physiology is important so baby can move downwards. And opening is the starting of the opening of the outlet. Once the baby will open up here, will come here, it will stay here for some time and let the body respond and give those hormones which important to relax the cervix. The cervix is the neck of the uterus. So uterus needs to contract, and then cervix needs to open, labor needs to start. So before, till the time, like if I just I'm into 9th month, but I haven't started my labor, it means the relaxing is not affecting the cervix dilation or not affecting the uterus. Smooth muscle is not affected. It's only the bone affected, muscles affected, connective tissue affected. They are creating space here and the baby move downwards. Okay. And this time when the baby move downward, baby movement is always, baby will get more space. Baby can start moving on the all directions. And sometimes baby might stuck into this position with in a bridge position. For example, baby should move, rotate actually in upside down. The head should come down. But sometimes if the baby is not shifting, is not moving, rotating, and baby is legs down first, so that baby, posterior side of the baby, the sacrum of the baby, you can understand, that will fix here. Assume that I'm a baby and my sacrum will fix on the side and my head in on the top. So when the back of the baby is stuck in here, so that can always put pressure over the sacrum, and patient can start having more sacral pain also. Or might be doctor will tell you that breech position is there. So now, if the breech position is there, so what we have to do, we have to take the baby away from this position. So we can give some positions to the female, which will help in increasing the space as well as taking the baby out. This is important that pelvic outlet should be ready and the bone should be ready, muscle should be ready. So for that, we can now start adding some stretching exercises, which we were not doing before because we were not putting pressure over the cervix. We don't wanted the cervix to open up. But in this 9th month, it is requirement of the baby, of the body to put pressure downward. So more outlets can start getting open up. So not only the bone, connective tissue, muscles, even the organs can start stimulating from the weight of the baby. Okay, and we really want uterine contractions also to be begin. So after 34 weeks onward, we are going to start all this kind of stretching exercise around the area, open up the area. So the deep squats is the first thing we are going to start. So ask the patient to go for do a lot of deep squats activity. Stay into this activity for 5 minutes in the morning, afternoon, evening. Repeat it 4 to 5 times in a day. Or start involving in all those kind of functional movement or functional activity at home, which involves this deeper squats, like mopping this floor, frog walk on the floor. So those kind of walks are very important. Walking on the floor with opening up. So they are going to relax the downward structure, and they will, if there's any tightness, we will then manually palpate the tightness as a therapist and we'll try to help. But first, the exercises is important. So what we'll do, we'll ask the patient to put a hot water packs or around the sacrum or around the pedal body. So these hot water packs are gonna soften the area and then go into this position. We can advise our female to dip herself into bathtub. So because water is going to relax, create a lot of relaxation downwards. The adductors will be relaxed, glutes will be relaxed, and it will be the accessory muscles which was around the bone, the all muscles should be relaxed first. And the soaking herself, the penile body into the water will automatically create a relaxation. Or you can sits bath, you can ask her to dip herself into the bathtub, small bathtub. So that will also going to help creating the relaxation. And the third is applying the hot water packs around the perineum or the sacrum or these regions. So heating is very the first thing which we will start. After heating, second is positions. We will give her those positions where she can stay there for some time. Whenever she's sleeping, we'll advise her to sleep in child pose position. So she can use some pillows support. So this is a good position, child pose position, where we have a pillow support, the complete one pillow anterior and one at the downwards. And she can just lie down on the pillow by opening up of her hips. Hip opener exercises, actually these are hip opener positions, these are. And we can use like this kind of yoga blocks also. So she can just sit on the yoga block like that, and it will help in creating relaxation down there. And deep squats, butterfly. We have to add lot of butterfly to open up the pelvic inlet into the third trimester. So the baby needs moving into the pelvic ring, out inlet. So this butterfly is going to open up. It is going to open up that adductors also. It is going to open up that pelvic floor also. Going to relax the pelvic floor as well as going to relax the all this hip openers, flexors. Very important. We will start giving her isolated exercises for every specific area. So you can give her piriformis stretches, you can give her adductor stretching, or you can give her pelvic floor stretching, or you can start very important to start adding that lunges, forward lunges, backward lunges, side lunges. They are important to add up. Open the area in all the direction. We don't want anywhere tightness. Okay, so accessory muscles stretching is important. Child's pose. We'll ask our patient to lie down like that and even try to sleep for 5 to 10 minutes. So it's a good exercise which is going to help in opening up. Leaning forward on the floor, leaning forward on the bed like this, or leaning forward by the support of the chair. Leaning forward is important. So this is which we have to start. Now, this is the warming up using the hot water packs or the sitz bath. Second is a positions or exercises, hip opener exercises, or like extensions, flexor, stretch. They all are important. So these exercises are important. And after that, we will now touch the area and feel that what is the status of the skin which is present around the penile body. So we'll ask our patient to after the sitz bath, when the patient will come to us, now we will check the perineal body. So we will advise her to, already we have stopped the Kegel exercise. So our focus is more into relaxation, reverse Kegel, opening up of downward part. So pelvic floor is very important for us, because through the pelvic floor only the baby is going to come.
Ma'am?
Yes.
Sorry, ma'am. Someone is waiting outside.
Okay. Can I make some admin? Dr. Neha, I'm making you admin. Can you keep adding the people? Is it okay for you, Dr. Neha? Okay.
Yes, ma'am, I'll do.
Okay, Dr. Neha. So we understood that we have given her all the accessory muscle stretch and relaxation, but very important is the pelvic floor stretch and pelvic floor relaxation. So what we will do, we will touch the skin of, we'll ask our patient to remove the clothes. And this is where the pelvic floor therapy is going to begin. Baby is going to come after crossing the uterus. After crossing the uterus, baby will come into the vagina, and at the lower part of the vagina, this is a vagina. So like this is a vagina, okay? So this is a vaginal canal. This is a uterus. So pelvic floor is present at the lower part of the vagina, like this. It's crossing like that. Vagina is crossing like this. So this is the end stop. So these muscles should be completely relaxed. We know that uterus will contract, it will push the baby downward, the cervix will open, baby will be moved towards the vagina, and vagina will dilate, extend, baby will come into the vagina. But after that, it might be hard for the baby to come outside because of this muscles which is tight around this vaginal downward part. So this is a vaginal cavity, and babies all around into the vaginal canal, but over here is the pelvic floor. If the pelvic floor are tight, baby will stuck into the vaginal canal. And this is what we are calling it's a prolonged stage 2 labor. Okay. So we have to relax that particular whole muscles around the vagina. So which muscle is crossing around the vagina is what I'll do. I'll send you one video, basic understanding of pelvic floor. Level 1 video is there where you can understand the muscles, how the muscles are rolled around the organs. So I have a recorded video I will share on the group. So it will give you understanding that which muscles are present. But let me name for you. Pubovaginalis muscle is the muscle which is around the vagina. So if this is a vagina, so this is a muscle coming from the pubic and crossing the vagina. So pubovaginalis muscle is creating the link, kink. So it's like okay. So to understand that, you understand first what is going on. This is the baby. This is the neck of the uterus. This is cervix. Okay. And this is a vaginal canal. And at the lower part of the vaginal canal, here pelvic floor muscles are present. These are the pelvic floor muscles. So when we talk about creating the space downward, we have to relax these muscles. Pelvic floor muscles are coming from ischial tuberosities on both sides, and they are attached with the pubic anteriorly and sacrum posteriorly. So the muscles are tight and they are not relaxed. So what they will do, they will not let them move. They will not let them open. So pelvic outlet will be restricted because muscles are tight. They are compressed tight. So they will not let it move anteriorly. So what is childbirth? During childbirth, what we required, we need an opening of the outlet. So this pubic symphysis should move upward like this. This coccyx should move downward like this. This movement we require. So this is what is creating the opening, isn't it? Look, increase the space, and lithotomy position is this one. In lithotomy position, they will put the legs up. So they will try to expand it. Okay. So this is the lithotomy position. So we need an opening here. And second is, if the pelvic floor muscle which is coming from the pubic to coccyx, we have a pubococcygeal muscle. So if the pubococcygeal muscle is tight, so this movement will be restricted. Okay, opening will not be there in anterior to posterior side. And now we have muscles coming from ischial tuberosity from sideway towards the penile body into the center. So this muscle, which we are calling, there are many muscles actually, which is coming around the penile body. Specifically, we have a superficial transverse perineum and deep transverse perineum. These two muscles are coming from the ischial tuberosity, like my fingers, they are coming from ischial tuberosity like this, and they are coming into the center like that. So if these muscles are tight, they will not let the ischial tuberosity to open on the side. We need ischial tuberosity to goes on side like this. Because baby is going to come out, we need opening. This should go down, sacrum should move posterior, coccyx should move posterior, pubic symphysis should move upward, and this should move outwards. This is what we are saying is what? opening of the outlet. So for this opening of the outlet, what is important? Relaxation of the pelvic floor. If for any reason this pelvic floor muscle is having a tension, or what can be the cause of tension? Might be that patient was having a tight pelvic floor before. A vaginismus case, it was initial, it was a case of vaginismus before and then treated, and then it was a case of dyspareunia, tightness into the pelvic floor, spasmodic pelvic floor, tight pelvic floor condition, tight coccygeal muscle, tight piriformis muscle, tight obturator muscle, any muscles which is around the area was tight. So tightness was the cause before, and she was treated, and then she was pregnant, and now till this time again the muscle can show that kind of spasm. Okay, they might hold the tendency to go for spasm. So that can be the one reason, or it can be female is fearful, and when she's in fear, whenever we are into fear, we increase the tone of the pelvic floor. So when she's anxious and she's in a fearful situation, she will always try to contract the pelvic floor. So if she will contract the pelvic floor upward, so it will not let it open up. It will create a tightness. Or she was performing Kegel up to 9th month, squeezing up. She was focusing into squeezing only, contraction only. So she don't know how to relax the pelvic floor. Or she might be during that childbirth process, what we want opening up of that area. So, but female is involved in, she's doing wrong breathing. She's doing a lot of exhale. She's doing this during the labor time period. So exhale means creating a contraction downwards. Okay. When we exhale and we exhale that air outside, so that is gonna move the diaphragm upward. Abdominal diaphragm will move upward, and that is gonna pull the pelvic diaphragm move upward also. So it is gonna create the closing of the pelvic diaphragm. So she's involved into wrong breathing protocol. That can be the situation why it is causing a tension. Or so she was keep doing that throughout the pregnancy. She was just only focusing on to exhale. She was not focusing on inhaling a lot. And third, it can be that she might be the second time mother, and second time delivery is going on, or third time going on. So there was effect onto these muscles from the previous birthing, previous childbirth. So she might go through episiotomy, perineal tears, and for that there was a scarring. The stitches happen, and because of the stitches there might be scarring. So the tissue, these pelvic floor muscles, they have a scar present into this area. So the perineal muscles are scarred muscles, and because of the scar, you can see the tissue will develop adhesions and tightness. And they will, next time when they will go, the baby will try to move out, they will cause a tightness around the region. So this is where we comes into picture in 9th month as a pelvic rehab therapist, that we will now touch the area. We'll ask the patient to open up, and then we'll observe the perineum of a female, and we'll look for any tight tissues, tight skin, any adhesions, any scarring. If she's a second time mother, so we'll ask her, and if then we'll palpate the particular scar, and we'll see the consistency of the scar. If it is a still tight scar, we have to mobilize the scar by perineal stretching. Okay, by doing the mobilization or myofascial release technique, lengthening technique with our finger, and or the opening up of this. So we have these muscles going on. So we'll try to relax the muscles and the fascia. So first will be exercise. So exercise which will open the squats, deep squats, lunges. So they will help in creating the relaxation. And before that, heating, then stretching. And the third will touch the area and will feel that how relaxed they are, and will teach our female the right breathing. We'll ask the female to inhale. When she will inhale, so this pelvic floor will go for expansion. So this is automatically expansion, the functional activity we have to teach her. So keep inhaling and feel that you are inhaling from your nose, and the air is going out from the openings. So pass the air through your anus. So we'll teach her this kind of inhale, bring the air into thorax by crossing the abdomen, let the air go into the pelvic floor and open the pelvic floor. So this is what the right breathing technique we have to teach the female into 9th month. So they will be automatically gonna create a relaxation. And the fourth is, now we'll touch the area, the perineal body, Be with me. I'll just bring the superficial layer of this.
Ma'am?
Someone was asking me something.
Yes.
Yes, please ask.
I just want to ask about the breathing techniques. Is it look like train maneuvers? Like we pushing the pressures downward the pelvic floor?
Yes, we are inhaling and try to open up try to bring the air downward. So it's like not a pushing. Pushing is you assume that you are pushing something from the down. Inhale. You want to do that with me, all of you?
Yes, please.
Okay. Okay, girls, let me teach you the right technique how to relax the pelvic floor with the breathing. Okay. So this is the whole muscles present here. This is a vaginal orifice. Through this orifice, baby is gonna come outside. Okay. Okay. So what is the effect of the breathing on the pelvic floor during childbirth? All of you inhale your air through nose. Feel the air in thoracic cavity. Feel your abdomen is going downward, and your balloon of abdominal balloon, your abdomen is also expanding. So inhale and feel the expansion of thorax and the abdomen. Feel it first. Yes. Now exhale. Again, do the same and feel the expansion of thoracic. And then how your diaphragm is moving down, abdominal diaphragm is moving down, and your abdomen is going for expansion. Balloon breathing. Okay, your balloon, abdomen is a balloon, and that is expanding in all the direction, anterior, posterior, sides, and downward also. The abdomen is moving downward also. Again, feel it. Did you felt it? The expansion? Did you felt? Yes or no?
Yes, but it's difficult to feel it.
Just this abdominal expansion. Just feel the abdominal expansion. Abdominal. Just expand your abdomen. Inhale and feel the expansion of the abdomen. Can you feel the expansion of the abdomen?
Yes, yes.
Yes? Okay. Now close your eyes. And when your abdomen is expanding, balloon is expanding in all the sides. So it is also expanding downwards. So feel that air is going downward also around the pelvic floor. The perineum is moving down. So feel the movement of the perineum, downward movement of the perineum when you're inhaling. Can you feel the downward movement of your air around the perineal area, pelvic floor area?
Yes, ma'am.
Okay.
Yes.
So when you're inhaling, again, feel the abdominal expansion. You again feel the air over the pelvic floor, this penile expansion. And now see what happens with your ischial tuberosities. You will feel that they are moving away from each other. Away from each other. Okay. Again, focus. Close your eyes. Inhale. Feel the air. Balloon is expanding downward also around the pelvic floor, and you can feel the ischial tuberosities are going on the side. Now exhale. When you exhale, your ischial tuberosity will close, your pelvic floor will go up, and your abdominal diaphragm will go up, air is going out. Feel it again. Inhale, everything is down, abdominal diaphragm, pelvic diaphragm, and ischial tuberosity is out. Exhale, ischial tuberosity is in, pelvic floor is moving up, abdomen is moving up, and air is going out. Did you feel that? Did you feel that?
Yes, ma'am.
Yes, ma'am.
All of you? Okay.
Yes, ma'am.
Inhale. Okay, first exhale. Ischial tuberosity is moving in. Okay, again exhale. Feel the moment of closing of ischial tuberosity. Palpate your ischial tuberosity with your fingers by putting your fingers down, your hands down. Do fast. Can you feel the activation of ischial tuberosity? Yes or no?
Yes, ma'am.
Yes. So exhale means they are contracting, they are closing. Inhale, they're relaxing. Exhale. Exhale. Inhale, relaxing. So ischial tuberosity will move in, out, in, out. Inhale, out. Exhale, in. So this is what we have to teach our patient, that inhale a lot, keep inhaling lot of air throughout the day. So when she'll inhale, palpate the sit bone and feel that they are moving outwards. If they are moving outwards, stay in this position for 6 seconds, 6 to 7 seconds. Inhale. And also we can teach another technique. So we'll ask a patient to inhale like this. It is gonna do that with me. And feel the movement around the ischial tuberosity. There will be more expansion. Did you felt the difference? Air is moving down, more down, and ischial tuberosities are going out, and hold it for 6, 7, 8, 9, 10 seconds. And then again exhale. Inhale more in 9th month. That is important. Okay. Inhale more. Exhale more was going on up to 8th month. But in 9th month, inhale more. Feel it? Ischial tuberosity is moving. Okay. Now exhale. Coming closer. Okay. Now the second type is hold the air, fill that air in thoracic, fill the air in abdomen. Abdomen is expanding in everywhere. Downward also, the pelvic floor will expand for more time. They will relax for more time. Ischial tuberosity will be out for more time. Okay, 10 seconds. Right now, do like that. Your ischial will automatically go away. So they're together, they are relaxed. This is how your TMJ is correlated with your pelvic floor. So you do filling here, relaxo TMJ, the more that you will do filling here, you will feel that your pelvic floor will also go for relaxation. Do like that and feel the movement down. They are activating, they're relaxing. When you're feeling air here, do like that. Did you find some moment when you're holding air here? You can feel that it's also relaxing. Yes.
Yes, I feel the air is going downward.
Yeah, you are feeling it's going downward.
Yes.
Yeah, so it means it is relaxing. So this technique we have to teach our female. Inhale more, hold air more. Okay, even that yoga where they are holding, Anulom, Vilom or Pranayam, they will be more into that time. And another is this kind of filling of water into mouth. Okay, fill the water, one like some sip of water, fill the water here, and stay like that for 1 minute, 10 seconds, 20 seconds. It will relax this whole jaws, TMJ. It will relax it automatically. It will put pressure over the ischial tuberosity. So these techniques will be more into 9th month, and we don't have to do all this technique before 34 weeks. If you do that before 34 weeks, you are loading the pelvic floor. But over here, we have to load the pelvic floors because baby is going to come from there. Understand? Clear?
Yes.
Okay, girls? All of you?
Yes, ma'am.
Now, the third thing, so this is the right breathing. And the third thing, we will now touch the perineum of a female. We'll ask her to lie down, and then we'll feel the adductors first, adductors. And we'll palpate the adductors at the groin region, that how, is there any tightness into the adductors? If there's a tightness into adductors, with our manual technique, massage technique, we will relax the tissue. So we'll give her myofascial release technique around the adductors, or opening up of releasing the adductors if they are tight. You try to find out any kind of tight band or tight tissue into the adductors. You can use cupping, use a cupping therapy and relax the adductors if they are having a spasm or tight adductor she is having. Clear? Relax the adductors, first thing. Because they are the first doors, they will keep closing. If adductors are tight, they will always create a tightness into the deeper muscles, deeper layers. Clear about adductors? Okay, girls?
Yes, ma'am.
Yes, ma'am.
After releasing the adductors, the second will be our finger will go over the ischial tuberosity. Now we'll palpate the ischial tuberosity of female, one side of ischial tuberosity. We'll ask her to go in sideline position, one sideline position, and the the ischial one leg which is up, upside on the top. The top leg will palpate the ischial tuberosity with our finger, and we'll press the bone in all the sides. We'll move like this and try to ask our patient, we'll try to see the facial expression of our patient. So when you're pressing the ischial tuberosity, we have many muscles attached into the ischial tuberosities. So if she's holding any tightness into those muscles, so this is the high time that we have to now add here lot of internal rotation and external rotation, both on one side. Okay, so by giving her that silent position, we'll first put a pressure over here, try to find out which muscles are tight. If muscles are tight, some trigger points are there around ischial tuberosity, painful areas are there, so that particular specific muscles we have to give stretching for. Or second is, we will ask the patient to go for external rotation, internal rotation, and then we'll ask the patient to go for flexion and extension, both in sideline. Okay, so extension, all these 4 movement on one side. And if she has some trigger points around the ischial tuberosity, some muscles are tight, we'll release the trigger point with ischial pressure, ischemic pressure. You apply the force, hold the force for 45 seconds to 1 minute, and try to reach the tight bands if she's holding here. And you can also apply your myofascial release technique or muscle lengthening technique as well, and activity, a range of motion exercises around this one side. After crossing this, it means one side is you treated, ask the patient to go on other side. Same way, you have to relax all the muscles which attach with the left side of the ischial tuberosity. And not only these muscles, even all this activity, range of motion exercise around that also. External rotations and internal rotations and flexion extension. Okay, both is important on one side. Then we'll ask our patient to go for quadruped position. So child pose position. So head leaning downwards. So let her go into the head leaning downwards. So this perineum will be, this coccyx will be up. So when the coccyx will be up, now we'll palpate the coccyx of a female and feel any tightness on this ligament. This is very important ligament, which is the area between the anus. So this is anus. These are the external anus sphincter, and this is anococcygeal ligament. And we have this coccyx. So this is a bone and this is a muscle. And between that, we have this attachment. Now, this particular ligament will be tight in most of our females. Why? During the pregnancy, throughout this, 7th, 8th, 9th month, she was in sacral sitting. And when she was in sacral sitting, her more force was always going on the back. And that can cause tightness into all these muscles, back posterior muscles. So coccygeal muscle, this muscle will be tight. If this because piriformis will be also tight. So piriformis and iliopsoas will be also tight. So we have to release the iliopsoas. We have to release we have to give a piriformis stretch also. And we will also relax the coccygeus, because coccygeus is somewhere touching, creating a tightness to the coccyx and the sacrum. Look, it is attached with the sacrum also. This particular part is attached with the sacrum. So we don't want this specific muscle tight. And there might be tendency of more tightness into the coccyx. Why? Because 83% of female, their uterosacral ligament is attached with the coccygeal muscle, not coccyx, coccygeal muscle. And if a uterosacral ligament, which is the ligament between the uterus and this posterior aspect. So once the uterus was expanding, so that ligament was stretched out. And because of the stretching out of that ligament, this muscle will be pulled anteriorly. And that will always hold some kind of extra tension. And that muscle, if this muscle is tight, it will create a tightness over the coccyx also. So all the muscles which was attached around the coccyx, like these muscles, these are coming from the pelvic floor, the posterior muscles. They are calling it as a iliococcygeal muscle, these ones, ischio-coccygeal muscle, this particular muscle where my finger is. So this ischio-coccygeal muscle, posterior fibers will be tight. And if they are tight, they will pull the coccyx anteriorly. And they will create, now they are merging where? Into this ligament. And this muscle iliococcygeal is also merging here, and external anal sphincter is also merging here. So external anal sphincter is a sphincter around, this is a pelvic floor, which is around the anal canal. So these sphincters are coming from the perineal body. So this is a perineal body here into center. So this muscle is going like this, and they are inserted here. So if this is tight, the levator ani, so this muscle can also is also tight, because mostly the female, they have coccydynia, and they also have constipation during pregnancy, very common. So because of they might have the tightness into that posterior fiber of external anal sphincter, and tightness into the anococcygeal ligament, and tightness into the coccygeal muscle. These, and the tightness over the sacrum, the muscles around the sacrum. Okay, they all muscles, we have to individually relax them. So give her stretching of all the back muscles, sacral muscles, and very important, you palpate the space between anus and tailbone. So palpate her coccyx, and the space is present here. Now over here, you apply the pressure with your thumb, small, just do palpation with the finger, and just keep feeling the tension. If you found that muscle is tender, or muscle is relaxed or tender, if it is relaxed, good. If it is tender, So apply pressure and see the facial expression of the patient. Sideline position. Okay, patient can be on sideline when you have to see the facial expression, because in prone you can't be able to see the facial expression. So in sideline, ask the patient to go in sideline and press it. So, and then when you're pressing it, and if facial expression are painful, and then you try to find out which area is giving her pain and give her relaxation of that particular region. So you can apply simple vibrator, the small vibrator, you can apply over this area, this part around the coccyx. Not a big vibrator, the small vibrator, or the gun which we are using, the physio gun. You can also apply around this region to relax this region, or in silent position, or just a simple, if you don't want to go for this gun or vibrator, you can just simply do the massage, kneading technique. You use your knuckle over here and you just do the kneading and release the trigger point and relax those tissues by this kind of stretching, this lengthening technique. Use lubrication, gloved finger, apply lubrication and do massage over here. So with the massage, you relax. And then after that, you ask the patient to go for internal rotation. When she'll do the internal rotation, this muscle will be pulled on the side. So try to relax this part with the internal rotation. Okay. So more internal rotation is required for relaxing the posterior aspect. Clear, girls? More internal rotation exercise should be begin into 9th month. And palpation of this part with the finger on sideline. So don't need to ask a patient to remove the panty. She can just remove the panty zone, and then with the panty, you can just palpate it on the sides. And ischial tuberosity you can also treat. Or you can apply hot water pack before that. Ask the patient to sit down on the hot water pack. Hot water, hot packs also. Clear? Hot packs, stretching exercise, and the manual release. 3 things.
Ma'am?
Yeah?
I have a question regarding the internal rotator exercises. We know that if the patients have a low back pain, we know that he or she have limitations in internal rotators. So can we start an exercise to increase the internal rotators in the second trimesters before 9 months?
We should try not to give her internal rotation. Internal rotation means you are trying to open up the downwards. Yeah, we can always give if she has a coccygeal, if she has a tight structures down back. Yes, definitely we can give her. If our focus is not anterior, it's just a posterior. She has a tension here, so you can give her internal rotation, but in sideline position. Okay, not standing. Sideline in quadruped is always good to give her internal rotation.
Okay, thank you, ma'am.
Not standing and sitting. Because standing and sitting, you unnecessarily put up, because baby weight will be down and you will compress the baby by doing this internal rotations. So no, not in that way. Otherwise, yes, quadruped and baby pose and sideline is always good for internal rotation exercises. Yes, we can begin it. Clear, girls? About the coccygeal, we call it as an anococcygeal ligament, and relax her anococcygeal ligament. Relax her ischial tuberosities. Muscles attached around the ischial tuberosities. So first we release that adductors, then muscles around the ischial tuberosities, and then the muscles around the coccyx. We relax. Then come on the top over the sacrum. Now we know that baby female is gonna go for lithotomy position, and the sacral muscles will be always unnecessarily more strained and loaded into this position. But yeah, we cannot, we should always be present. If we are fortunate enough, we might give them position during the labor, but mostly the doctors are gonna give them lithotomy. But if lithotomy is also there, but at that time the coccyx should be free and should be relaxed. No tension around the anococcygeal ligament, no tension around the ischial tuberosity, and now all the muscles which is attached with the pubic rami, ischial rami, they should be free, because this area has to go for expansion. So those muscles which is attached here, they should be relaxed completely. They are going to create the opening. So this was the external muscles. Now let's talk about the central muscle over here, pelvic floor, central perineal muscle. So we have a perineal body, and into the perineal body, now we have how many muscles? 6 paired muscles are gonna attach into the penile body. And baby is going to come from the vagina. So through the vagina, now which muscle is around the vagina? This is the muscle. Can you see the first muscle? This one, which is going from the downward, and this muscle is going upward like this. So this is the bulbocavernosus muscle, which is all wrap around. So coming from the pubic, this ischial tuberosity, penile body, and going upward, and it is attached with the clitoris of a female. So this is the body of the clitoris. It is attached with the body of the clitoris here. So this muscle is very important. Okay, from one side, and the other muscle is going on the other side. So assume one side of ischial bulbo and other side of bulbo around the vagina like this. So these muscles should not be tight, and they are always having the trigger points and adhesions and scarring in previous childbirth when there was a stitches. So episiotomy was there, penile tear was there, there were stitches, so they create that kind of adhesion. The tissue was adhere. Assume that this particular area is having tightness. If this tissue is tight, so when the baby will come out, it will not let the baby to open up the vagina around this side, because these tissues are having adhesions. So individual bulbocavernosus is very, very important muscles. We have to palpate and relax. So you touch the bulbo, but does the bulbo like this, up like this, and try to feel any tightness into this muscle. If you found there's a tightness, you relax these muscles with the massage technique. You do the massaging, relaxing, opening, stretching massage, okay, releasing massage. So release the fascia over that. Or another muscle which is coming, bulbo one side, other side, two bulbo is there, right bulbo and left, and they are merging on the center. So merging point should be also released. So it will help in creating an opening around the vagina. And not only this muscle, even we have this muscle also coming from the ischial tuberosity. So this is superficial transverse perineum. This muscle is coming from the side, and that is attached into the penile body here. If this muscle is tight, it will not let the ischial tuberosity to open up because of the tightness. The structures are tight, that short. That will be always in case of previous history of mediolateral episiotomy. If female had a cut in previous previous childbirth over here, mediolateral, so it was a cut into bulbo because baby was stuck, and they created a cut into this skin of the vagina, vestibule, vaginal layer, vestibule, and then they cutted this bulbo, and then they create a cut into the superficial transverse perineum. So after that episiotomy, mediolateral episiotomy, there will be adhesion present into this side of muscles, superficial transverse or this muscle. So during the next childbirth, this shortening of the muscle, the tightness of the muscle will not let the baby, will not let open the vagina. It might create restrictions. So we have to then relax those adhesive or the scarred tissues with our finger by doing a lot of massage technique. So use lubrication and do massage around the area. Try to relax the area with your finger, your thumb. Try to do the relaxation, okay? More relaxation, like that, of these muscles, okay? The sideways muscles. So bulbo is very important, and this one, superficial transverse perineum, is also important. And now, if I rotate it on the side, other side, so we have another muscle which is coming beneath the superficial transverse, that is a deep transverse perineum. So that muscles also got cut during the episiotomy, mediolateral episiotomy. So there might deeper tissue, deeper muscles tightness can be also present. There are 3 layers which is present around the vagina. If this is a vagina, and you can see this opening over here, so vagina is fitted like that. So this is pelvic floor with the vagina, okay? So a baby, okay, it's okay, baby is coming, uterus is doing best, it's bad, labor began, uterus, baby moved into the vagina. So labor stage 2, but now over here, down here, baby stuck. Doctors are telling the female to push, but the muscles are tight. Look, where the baby stuck? What is there into the center? What is here? Where the baby stuck? We don't have any hard tissue. So then where the baby stuck? Baby stuck into pelvic floor always because of these muscles tightness. Okay, so these muscles are very, very important that we have to relax those muscles. Now, how many muscles are present? As soon as baby will come down, the first muscle it is gonna touch is the levator ani. This muscle. So this is levator ani. And on the top, we have then middle layer of the pelvic floor. This muscle, urethrovaginal sphincter, and outer is a bulbo. So let me attach. Let me attach it like this. Okay. So I attached 3 layers, and now let me attach the vagina. See, baby will come. Assume this is a vagina. Baby's hair into the vagina. Now this is the first thing that this muscle which is coming across the vagina. Look, across the vagina muscles are going from levator ani, all the sides, both sides. So this particular muscle which is coming from pubic to around the vagina, we are calling it as a pubo-vaginalis muscle. So one side of pubo-vaginalis will come like this, and it will merge with the other side of pubo-vaginalis muscle. So right side and left side pubo-vaginalis will merge behind the vagina. So this is a vagina, and this is one part of pubo, and this is the other side of pubo. They will merge together across around that sides, posterior sides of the vagina. If these muscles, pubo-vaginalis muscles, are tight, they will not let the baby pass downwards. So this is the first layer, deeper layer of the pelvic floor, which is creating a looping around the vagina, pubo-vaginalis muscle. After this, the second layer, the middle layer, we have a urethrovaginal sphincter. So from the vagina, some muscles are coming. Now from here, muscles are coming and going around the urethra. So these sides, these sidewise muscles, this is the fiber of middle layer of pelvic floor. So we call it as a urethrovaginal sphincter. If these muscles are tight, they will not expand the vagina. So in this whole structure, we have a vagina, lower part of the vagina. Okay, they are attached. And after that, this part on the sides, can you see this one? This is a part of the bulbo. Okay, this is the bulbo muscles. So if these muscles are tight, they will not let the vagina to open up. So to relax, to let the baby come out, we need relax levator ani, deeper muscles, so they can stretch out the pubo-vaginalis muscle fibers. We need relax this muscle, this one, urethrovaginal sphincter, urethrovaginis. They are going from the vagina towards the urethra. So this is the sphincters, like a middle layer, and the outside we have this one, bulbo. This muscle should be also relaxed. So these 3 muscles individually we have to relax by giving her, starting from the external rehab. So we'll palpate the ischial tuberosity. If we will try to look for any tightness here, any tightness in ischial tuberosity, any tightness of other ischial tuberosity, and if there is, we'll release those muscle fiber with all this technique, relaxation technique, lengthening technique, or the exercise, range of motion exercise. Okay. After that, we'll apply heating over the perineal body here. Apply heating, release those tissues, the skin and the subcutaneous tissues. After releasing that, we'll get some kind of softening into the muscles also, and then we'll find out the tightness here. And if there's no tightness, good. But if there's the tightness, then we'll release the tightness with the myofascial release technique. Always do outward strokes. So from middle to out, opener. So we'll ask the patient to go for internal rotation and do the massage, external massage by pressing the tissues. Lengthened. So assume this is a tissue, so you do lengthening with your finger, this kind of massage by using a lot of lubrication. Okay, relax these tissues with the deeper pressure. But this pressure should not be painful for your patient. It should be just releasing pressure. And you are releasing one side, you release the other side, and then release the central part also. This perineal body also, release this part also. Release this external anal sphincter also. We don't want any tightness into external sphincter muscles, because if this muscle will be tight, they might create a tearing during the childbirth because of the tightness. So we'll release those muscles also, external, by doing the massage. So do massage like this massage, release the tissues. Okay. And the central part here with your thumb, both thumb you can use like that, do the massage on like that. In this way, we need to, you can ask the female to remove the panty, or you can just shift the panty on one side. Don't need to remove because you are still on the around the easter tuberosity. Okay. So you can relax. But once you have to relax the bulbo, she has to remove the panty. And then we will release the bulbo, these muscles. After that, after raising the superficial and bulbo, then we'll go into the vestibular area. This is skin around the vagina, this skin. So we'll touch the skin, and this is what we are calling it as a perineal stretching. Vaginal muscle, tissues, release of that muscle, vaginal tissues. So what we'll do, this is our finger, we'll insert our finger over the lower part, inferior part of the vagina. So we'll not insert finger inside. We are just on the outer part here. The vestibule, this is the vestibule, okay? This is the upper labia minora flap. So this is the lower part of the labia minora. When the left labia minora and the right labia minora, they are joining together here. Look, this is one side, right and left. They are joining together. This particular part where this both flaps are joining, we are calling it as a vaginal fossa. You all know that. In this vaginal fossa, we'll insert our finger like this into vestibule, 6 o'clock. So assume this is the clock, and 12 is always up towards pubic symphysis. 6 is always down. Assume there's a clock here, 12, 1, 2, 3, 4, 5, 6. So 6 is downward. So 6 o'clock, we'll touch with our finger. And we'll try to release those tissues with our finger. We'll do massage, and we'll do the strokes, downward stroke. So we'll do the massage like downward massage. We'll stretch it. Assume this is a tissue. These are the tissues. So we'll insert our finger at 6 o'clock, and we'll try to stretch it downward, the skin, with the finger like that. Keep stretching it. Do massage first, stretching massage downward like this. We'll try to open up the vagina like that. Down, stretch downward, 6 o'clock. So we'll spend approximately 1 minute of time into this stretching. Keep doing it. Stretch, hold the tissue, hold 1, 2, 3, 4, 5, down. Again, relax, again, pull it downward with your finger, open up the downward part of the vagina. Now, after doing 6 o'clock, you go on one side, 5 o'clock or 7 o'clock. Stretch the tissue around 7 o'clock. Again, spend 1 minute, then go on 5 o'clock, other side. Stretch those tissue also other side, then again come on 6. And then you have 5, 6, and 7. You do scooping. Open up this tissue like this. Move your finger like that. Okay. So like here, I'm moving my finger. First, downward stretch, 6. Then this side stretch. Then this side stretch, 1 minute. Then just scooping. Scooping, ice cream scoop. You do the scooping. 6, 5, 6, 7, 5, 6, 7, those tissue. And after doing that, you go towards the 4 o'clock, other side. So you did 6 o'clock, you did 5 o'clock and 7 o'clock. Now go on 4 o'clock. Then go on 8 o'clock. Now you have more tissues, 4, 5, 6, 7, 8. Do again scooping. One side, 4, 5, 6, other side, 8, 7, 6. 4, 5, 6, 8, 7. This again spans some 1 minute this side, 1 minute this side. Then you insert, then you relax the tissue around the 3 o'clock. So relax here, you relaxed here, you relaxed here. Now you go around 3 o'clock of the vagina. So this is vagina, and this is 3 o'clock of vagina. So we'll stretch the vagina on the side. So you can, with your one side like this, one finger, and even both finger, you can stretch like this. Okay, open up around the vagina. Okay, these tissues, this side of the bulbo. Then 2 o'clock of the vagina, upside. So the whole bulbo is relaxed outside. Now you insert your finger, open the vestibule of a female, and then lubricated gloved finger you insert inside the vagina. And ask the female, before going it, you ask the female to do inhale. So when she will inhale, we'll see that eastern tuberosity will move down and the opening of the vagina. So right now, if you'll do reverse Kegel, inhale, so your vagina will open up like that. So this opening we have to see. So inhale is the second, breathing is the second thing which we have to now add here. So we were doing this release of the muscles, accessory muscles, adductors, piriformis, coccygeal, all these muscles. Then we came into the penile muscles. We relaxed the superficial transverse muscles. Now we relax the bulbo muscles. Now we are going inside the vagina. We are asking the female to do this inhale so we can see the opening of the vagina. And then after that, we'll put our finger here and we'll feel that when she's opening up, our finger is pushed downward. We can feel this relaxation on our finger. So like that, you just put your finger on the top and ask her to exhale. When she will exhale, our finger will feel some relaxation on the tissue. Look, squeeze, relax, squeeze, relax. This kind of tension we can feel. Look, squeeze, relax, squeeze, relax. Our finger will feel that, yeah, it is relaxed muscle, relaxed tissues. So there should not be any tension. It should be complete relaxation. And we have to feel this relaxation. Then what we can do, we can keep inserting our finger bit slowly inside the vagina. Okay, just only half knuckle of your finger inside. And after going in, so still where you are not inserting your finger inside the vagina. Look, this is the vagina. Okay, we are not inserting our finger inside the vagina. We are inserting our finger only into by crossing the bulbo, half knuckle. Okay, we are just into this part of the vagina, middle part. We are just inserting half knuckle. Now you relax the deeper tissue of this muscle. The same way downward, 6 o'clock, 4 o'clock, 3 o'clock, other side of 7, 8, 9 will relax. We keep inserting our finger more inside and then our finger will touch levator ani. Assume that by crossing this outer part, my finger is now here into the levator ani. Look, my finger is not inside the vagina. It is just a one knuckle inside. By crossing half knuckle, one knuckle. Now we'll feel the bulbocavernosus. Now we'll pull the bulbo downwards, 6 o'clock downwards. And keep stretching it down like this with the finger, 6 o'clock. We spend approximately 2 to 3 minutes in relaxing this levator ani muscle. Pull it downward. Hold it downward, hold it for 45 second release. Again, hold it for 45 second release. Again, hold it for 45 second release. So we'll do 6 to 7 times, 6 o'clock. Then we'll move our finger on other side, 5 o'clock. Again, we'll do the same, stretch downward. Other side again, stretch downward. So this is a whole loop of pubovaginis muscle, 6, 5, and 7. So we'll relax this and then keep moving our finger on the side. 8 o'clock, we'll relax on the side. We'll again stretch the tissues like this. Look, this is outside is going on. Look, this is going on the outside. Stretch, stretch, stretch. The more far your finger can go, stretch more. 6 o'clock, 7 o'clock, 8 o'clock, 9 o'clock, 10 o'clock, complete stretch. Okay. After doing one side, you do the same on the other side. Spend enough time, minimum 10 minutes inside. Then after that, you can just stay here and ask the patient to inhale. When she will inhale, you will feel this muscle is going for relaxation. It means the breathing is done. If it is not, then you have to re-educate, keep educating the breathing, right breathing. And then after doing, then you insert your finger on 9 o'clock and you have to now go on a side. We have a deeper muscles of pelvic floor. These are the muscles. This is the obturator internus muscle. We'll palpate the obturator internus. We'll palpate iliococcygeal muscles. And we'll look for any trigger point, any pain into these muscles on the side. We are not inside the vagina. We are on the muscles. We are stretching the vaginal tissue on the side, lateral side, and we are on the muscles. Palpate the muscle, find out any trigger point, release the trigger point, come outside, go on other side, same way, all the muscle, relax, come outside, okay? This is how we have to do the transvaginal approach. For that, you can join, you can get my recorded session access, or you can join my own, workshops also, in which you can practice that. You can practically feel all this in your body. We will do that in practical sessions. And this, after this vaginal, then you can always start with the transrectal in case of pregnant female. If you don't want to go inside the vagina, you are afraid, you can always go inside the rectum. And by inserting your finger, you can relax those muscles by the transrectal approach. With your finger, you can insert, and you can relax all these muscles by inserting your finger on the sides, and even the muscles which is merging around the coccyx also, or muscles which is coming from the ischial spine on the one side. You can relax the ischial spine, these muscles. You can all go all the way from the vagina transrectal approach. Your finger can come here. You can your finger can come up, side, this side, this side. You can relax. Transrectal and then transvaginal. After doing the relaxation with your finger, once you feel that your female don't have any pain inside and she has relaxed tissues, then we will ask our female to go for some kind of tool throwing. We'll use dilators inside the vagina, not inside the vagina, sorry. We'll use dilator. We'll always start with the smaller dilator. We'll insert that dilator by marking on the dilator. Like assume that I'm putting mark here. I'll put condom, and then I'll mark like this. Okay, so this is the only this much of only we will insert inside the vagina, and this is the vagina. Now we will insert that only up to the door. Okay, only up to the door, and then stretch it downward. So this is door, and stretch the tissues downward. And we'll ask the patient, can she feel it? And yes, I can feel. So we'll not insert like that. It should be just a half knuckle dilator inside vagina. So after inserting this, we'll ask the patient to, can you feel it? Something is inside? Yes, I can feel. Okay, throw it out. The baby, she has to throw it out. So now she has to throw this, whatever she's feeling here, she has to throw it out. So relax, throw it outside from your vagina. So this is what she has to do. Take an inhale and throw with your vagina, like you are voiding something downwards. So apply the voiding force. So in this way, the abdominal will also contract and this breathing will also help in creating the relaxation. So throw this dilator, the minimum size of the dilator. Once you can throw this one, or if you don't want to go with that, you're afraid, might be, that is because these are the hard, kind of long, hard, might be she will just insert, it might damage her. So for that, you can use a simple, if you have a perinometer with you, that is a pelvic floor device, actually. So this is the perinometer. You can insert this tool of the perinometer inside the vagina, only this much. You can see the circular part, not the whole length, okay? It's only this much part, which is bulgy part. So only this much you can insert inside the vagina like that and ask the female to throw it out. So she has to throw it out. And if she's not able to throw it out, then we'll ask her to, okay, just stand up. So she can stand up and then she can insert only up to this. The whole part is out and try to throw it out. In this, gravity will help her to throwing it out also. And from top, she can use intra-abdominal pressure also by doing this breathing. So pressure will apply by here, and pressure will be, the pull will be also from the pelvic floor, from the gravity. But we know that she's not going to deliver the baby into this position because gynec is going to give her lithotomy position. So that will be against the gravity. So gravity role will not be there. But we will always start teaching the female from the gravity, against the gravity. Then when she can throw it out into this by Valsalva and by this downwards, the gravity also, we can, if she's not able to do that, then we'll ask her to go for squats. So when she'll go for squats, automatically it will fall out. So once it will fall out, it means she can do in squatting position. Then we'll ask her to just stand up and try to throw out by widening the legs. So throwing out is the main purpose, because baby, she has to throw the baby outside. So we have to relax the pelvic floor and we have to train the pelvic floor in that way that she should be able to throw it out. And if another thing which we can do, we can ask the female to lie down in a crook-line position or quadruped position also. So we can always start with the quadruped position and ask the patient to we'll insert that inside the vagina and we will put a condom on top and then we'll insert this much only, okay, this much. We'll ask her, can you feel the probe? Yes, I can feel the probe. And we can see that whole probe is outside by condom on it, okay? Same device we can use on different female. And then when this is inside, and now we see the needle should not move, this needle in the spirometer. So the needle should not move. If the needle is moving, like for example, the needle is moving, it means she's creating a tension. So if the needle is at the zero, it means relaxed pelvic floor. It is relaxed completely. So she's holding something, but she's not creating tension. If there's a tension, so we'll ask her, look, can you see the needle is moving up? No, don't just completely relax. Relax. So remove the pressure on the probe. Don't hold the probe. Just completely relax or inhale a lot. So when she will inhale, automatically peripheral will move on the side and automatically the needle will go downwards. Okay, this is the retraining we are giving her. So needle should not create a contraction. When she do the contraction, then needle will move upwards. Okay, so no contraction, just relaxation. And when she can do this one, we have a different size probe. So 1 size, 2 size, 3 size, you can go for more wider probe. You can insert the wider probe and do the same training with the patient. And baby is not like this. Baby is bigger than that. So we can use another device which we have in our practice is this one. So assume that this is a baby, okay? So only this part, this much upper part will be insert inside the vagina like that. So she will hold this, only this part will be inside. Assume this is vaginal muscles. Vagina is inside. This is the pelvic floor muscles we are talking about. We are not inserting it inside the vaginal canal. This is the canal. We're not going inside the canal. We are just out. We're not inside the vagina. Okay, we are outside into the vaginal muscles, pelvic floor muscles. We'll insert that into the door up to halfway. Okay, only up to like whole part we can see it is outside. After that, we'll ask the patient, can you feel it? Yes, throw it out. So this is a more bigger dilator. So she has to throw this out into all the positions, quadripod position, childbirth position, lithotomy position. Once she can throw it out in lithotomy position, it means she's good to go because doctor is going to give her lithotomy. So in lithotomy, she should be able to fall it. But if she's not able to let it fall, so then we can begin the practice from this gravity assisted actually, standing with Valsalva or standing with squats and then standing and then crook line position. Okay, and then after this crook line, the last will be the quadripod position. She has to throw this out in a quadripod position. So quadripod means completely eliminating the gravity. So that will be, this is what we have to train our female, that she should be able to throw any object into quadripod position. So it means she's having a complete relaxed pelvic floor. When she can throw it out in this, so what we'll do, we'll keep increasing the size. So again, we are having, we can increase the pressure here. Can you see this pressure is increasing? You can keep increasing more bigger diameter. So now the diameter is more. So now, can you throw it now? Can she throw it out this much? If yes, then keep increasing the diameter more. It will, you can, this is a balloon which will keep inflating inside the vagina. And that is gonna create a more relaxation into the vaginal muscles. If she can throw it out, this kind of inflated and bigger, tensed, more resistance is there and she can throw it out, it means she's ready for the baby childbirth. This is the perineal preparation. So this perineal preparation will always start by creating the core muscle relaxation, the muscles which is attached around the pelvic bone, every area, pelvic bone, and then muscles which attach with the ischial tuberosity, attach with the pubic symphysis, attach with the coccyx. These muscles should be relaxed. Adductors, all this, okay, piriformis, accessory muscles, glutes, piriformis, hamstrings, iliopsoas, everything should be relaxed. After this accessory muscles, then we'll go to the pelvic floor. And pelvic floor will be first superficial muscle, this layer. The muscles which is attached with the anococcygeal region. So this muscle should be relaxed first, external anal sphincters. Then this muscle, penile body. Now, which muscle is coming around the penile body? Superficial transverse should be relaxed. Second. Third, bulbo should be relaxed. Fourth, our finger will be more towards the vaginal orifice. This vaginal tissue should, and the skin should be relaxed, or adhesive part and scarring, that tissue should be relaxed. Then we'll keep inserting our finger and keep relaxing this, doing this penile stretch around 6 o'clock, 5 o'clock, 3 o'clock, everywhere by this stretching downward and tissue stretch or the ischemic compression, if there is any trigger point, or the scooping massage. Okay, and then insert your finger inside, ask the patient to throw your finger out. With now the breathing, we have to teach cooperates with this the same with our treatment. So she has to start with good right breathing, breathe in actually. And then we'll move our finger more on the side, levator ani. We'll look for any muscle is holding any tightness in levator ani, one side, and then we'll move our finger on other side of levator ani. We'll relax the muscles on the through transvaginal and transrectal approach. After we feel that she can throw my finger outside, we'll ask her to push my finger out. When she can push my finger outside through the vagina, through the rectum, then we'll start inserting those kind of soft tools. These are the very soft. So don't go for dilator, go for this kind of soft tools. You can start with the perinometer, or you can just only start with this. You can just deflate it, remove all the air. Okay, so you can remove the air. You can fold it up. This is just a tissue. This is very soft plastic. You can put a condom, and this will become like a finger or double finger. Okay, you can just insert it and then ask her to throw it out and keep inflating, and you keep training the female in all the position. One day she will be able to throw this out in quadripod. It means she's ready, and the bigger size of this. So it means she's ready for childbirth. Okay. Her perineal is relaxed, and this female will not have any. You can minimize the chances of episiotomies and perineal tear by creating this kind of preparation of the vagina. This is physiotherapy, actually.
Ma'am,
Yes, dear.
if the muscles doesn't stretch it out, does that make her birth in a C-section or cesarean?
Like it might not C-section, it might obstruct the passage, and doctor might have to do more bigger cuts, mediolateral episiotomy. They will do the cut, or they might go for vacuum extraction or forceps delivery. And if still that will not be able to, might be patient will be shifted to for the C-section. Labor C-section. We'll say the female has gone through the labor process, and because muscles were tight and baby was not able to come outside, female was also tired, and it is the baby position which is deteriorating, and female is also bleeding. So just to unnecessarily avoid this kind of complication, doctor might shift her for the C-section also. She can be shifted if the pelvic muscles are tight. Yes. Okay, girls. This is the role of physiotherapy, preparing your female for childbirth. Clear? Let me show you the screen. Okay, so I already told you that how to do that, do the relaxation of the muscles. Pelvic floor muscles should be more important. To reduce tightness and improve blood circulation around the area, pelvic floor muscle lengthening techniques are very, very important. We will palpate each layer of pelvic floor to look for any tightness, scarring, or adhesion. If you found any scarred or adhesive tissue around the pelvic muscles, do scar mobilization by lifting the tissue between the thumb and index finger and apply rolling technique. If your female have some scarring tissue, assume that this is a tissue. This is index finger and thumb. You just pull it, pick it, and then do rolling, like this kind of rolling of those tissues. Okay, do this rolling technique and mobilize that tissues. Okay, you can do this kind of circular rolling also. You can apply that, or vertical up, down around the scarring tissue, or lengthening, like use both finger and move both finger on opposite direction. Okay, like this, you can lengthen up. So these are the different techniques which you can use to reduce the adhesion. If you found any scarred or adhesive tissue around the pelvic muscles, like external anal sphincter, perineal muscles, external anal sphincter, midline, or this deep superficial transverse perineum or bulbocavernosus. So do scar mobilization by lifting the tissue between thumb and index finger. Apply rolling technique or kneading. If you found any tightness, it is important to lengthening the muscles by using different muscle lengthening and mobilization techniques like ischemic compression for trigger point release. Find the tight spots. Use your finger to press firmly into the trigger points. Pressure should be sustained for 10 to 20 seconds minimum, and maximum you can go for 45 seconds. And gradually you can keep increasing that pressure and release that area for up to 2 minutes on one spot. Do these techniques only 2 to 3 times and then move to the other area. Soft tissue mobilization is a gentle massage and gentle stretching used to mobilize the skin, fascia, and muscles, which may be found bound down, shortened, or immobilized due to the pain. So try to relax the area by doing the circular strokes, vertical strokes, or horizontal strokes. Give different position and movement, which helps in creating stretching like deep squats, butterfly, to release the tension from the adductors too. We already did that. Perineal preparation for the labor. So this is what I have already explained to you. 3, this is the clock, which is you have to assume around the vagina. Baby is going to come from this area. So from here, baby will come this area. So you have to do all the complete relaxation around this area. So we have a superficial transverse perineal muscle, bulbocavernosus muscle. So we have to relax these muscles importantly. Perineal stretch or perineal massage. Therapist can start perineal stretching or massaging followed by warm compression. As I told you, use a pad or cloth for the compression to create softening around the perineal skin and tissue around the vagina. Start perineal massage by wearing sterile glove and lubricated finger. Insert only one half knuckle actually, just very downward part. You apply any oil for the lubrication and do this kind of stretching by applying the downward pressure at 6 o'clock. For minimum 2 minutes, 1 point, you can spend 2 minutes on 6 o'clock. Then repeat the same technique between 3 to 9. So you did on 6, then you do on 5, then you do on 7, then you do on 4, then you do on 8, then you do on 3, then you do on 9. So repeat same 2 minutes you have to spend in everywhere externally. Then you in total spend minimum 10 minutes and do that 2 to 3 times in a day. So we have to do and we have to teach this to the female, or we will ask the patient, the female, to bring her partner. Now partner can do the perineal stretching for her 2 to 3 times. This techniques is going to relax the perineum, the area between the vagina and the rectum, and helps in soften the skin tissue around it. It can decrease the likelihood of tearing during the delivery. It can minimize the episiotomy or perineal tear. Practice relaxation technique and right breathing technique also. Don't hold your, it's not like don't exhale a lot, okay? Focus on inhaling the air from nose, move it down to abdomen, push the air out from the vagina. Inhalation moves abdominal and pelvic diaphragm downwards and helps in relaxing the pelvic floor muscles and the tissues around. Push technique. We have to teach how to push during delivery by inserting those kind of tools which I told you. Teach how to push during delivery without holding the breath. Focus on your vaginal area, feel proprioception by using any tool like Apino, with the tool which I told you, or any peniometer or any menstrual cup. You can insert a menstrual cup and ask the female to just throw the menstrual cup outside. Using mirror biofeedback, you can also show the mirror to the patient that you can place a mirror, small mirror, handheld mirror around the downward. She can look the perineum into the mirror and try to throw this thing outside by looking into the mirror. So it will give her a proprioception also, and it will also give her a tactile biofeedback, and it will also give her a visual biofeedback. And we will be also there to give her audio biofeedback. Push, push, push. We'll keep giving her these 3 biofeedbacks. The brain will understand, and this is a re-education to the muscles for relaxations. Push technique by using using mirror biofeedback will make it easy to understand for her. Push only when we are telling her to push. Otherwise, do not push. So whenever I'm telling her push, push. If I'm not doing anything, stay like this. Okay, and this is what is very, very important: perineal preparation for the birthing. You can take a screenshot. So we will sit like that with our patient and keep doing this with the patient. These are the instructions for perineal massage, how to do, when to do, and how to teach the partner also, and involve the partner, teach the partner. This is a U-shaped massage actually, which we are doing around the perineal body, all this region. Okay, and she can do the same with the rectum also. She can insert the finger and relax the rectal area as well. She should not have any tension into the rectal muscles, transrectally. And breech, if the patient is having a breech position, baby is moved, the baby bottom is downward, stuck down there. So we will, this is again position which we can shift the baby into the normal position. We can increase the movement of the baby by giving her those simple inversion techniques. Okay, baby is down, stuck here. So what we have to do, give her this position, lower down. So she can, this assistant should be there. Anything like we should be supportive at that time. So we'll ask the patient to sit down on the sofa and then keep leaning her body downwards. So leg should be on the sofa, feet should be on the sofa, and then she's leaning forward like that. So this, in this position, the baby will move towards the abdominal cavity. And once it will move downwards in the abdominal cavity, we'll ask the patient to roll out, shift the hip swaying. She can start swaying the hips on the sideways, right side, left side, or front and back. So let the baby to move downwards and do lot of kind of shaking of the hips. Okay, that swaying and shaking of the hip. So that is gonna move the baby to come out from the pelvic cavity, and it will go towards the abdominal cavity. And after that, slowly the baby female can go in a silent position, one silent position, and let the baby to move on all the sides. Or quadruped will be also good. After this, she can go for quadruped, and then from that she can go for this leaning forward, a childbirth position, and she can also go for pelvic bridging position like that. So this is what she has to keep shifting the position for 10 to 15 minutes every time throughout the day. So this will help the baby to move away from the pelvic bone and shift. It might help in shifting the baby in a right position. Or apply sound on the upper part of the uterus over here. Apply sounds. So if your baby is here, so keep shifting the sound in this side. The more you will shift the sound, the baby will try to move towards the sound. Okay, so that is also gonna help the patient, the baby. Or the temperature, you can also apply the temperature, hot or cold temperature around this area. So according to feeling this, because you understand, once the baby uterus is more expanded uterus, so the uterus wall will touch directly to the skin of a female. So as soon as anything will be applied over and the muscles will be on the sides. Okay, the rectus femoris, the rectus abdominis, they will go on the side. So linea alba will be stretched out. So the muscles, abdominal muscles will be very, very thin out muscles during the pregnancy in 9th month. So whatever you'll apply over this is what you might have feel this baby, feet movement, is like a visibility of the feet of the baby when it is moving inside is very, very palpable and movable. And visible is also there. Visibility is also there, that they can see their legs or you can see their feet, or that, because this tissue is just attached with the skin. So whatever you'll apply over the skin, the music or the hot or cold, it will increase the movement of the baby. So these positions, as well as the placing the different type of temperatures around that area, will also increase the movement. Induce labor, guide her around 40 weeks. If yes, we can also help in inducing the labor. And how to induce the labor? If the labor is not started and she's saying that, oh, I have finished my 9th month, still labor is not there. When I'll have my baby movement is down, doctor is saying that your amniotic fluid is like it's very low and baby is not moving. So might be female will be anxious. So in this case, we can suggest her to induce the labor. So induction of the labor is depending upon the hormones. So we need oxytocin release, and oxytocin will be there. That oxytocin is going to create a labor. It's going to begin the labor actually. So oxytocin is a good hormone, love hormone. So the more she will feel loved at that time, so we have to advise her to keep touching herself, her partner, keep hugging the partner, and start creating the love making with the partner. More she will hug the partner, the more she will feel good, more the oxytocin will be released. And the second is hugging is very, very important, and touching, feeling that proprioception in a body. So the sexual organs, all the secondary sexual organs, she has a breast, she has a vulva, and she has a labia majora. So she should start touching her sexual organs, breast, and start stimulating the breast, or start touching the breast, or start massaging the breast, start touching the areola, start touching the nipples, pull the nipples outwards. So that is gonna help giving this good proprioceptions, and that will give a signal to the brain that she's liking this touch, and the oxytocin release will be more. We'll also advise her to start having like masturbations. External, when she'll feel the masturbation, the muscle will go for relaxation, and she will feel good with this, having this external sexual touch actually, and masturbation. She will feel good. Or we'll also advise her to involve into sexual activity with the partner. And so partner can do the stretching exercise of the penile body. This is why we want the partner to be involved into penile stretches. So more the partner will be involved, female will feel good when the partner will touch her sexual organs, the vagina, because this is what is the the intimate life is actually. So when the partner will touch the vulva, partner will touch the penile body, the good release of the hormone will be always there, and oxytocin will be good. And even partner might also get attracted towards the female, and they might ended up into having the sex, doing the sex, that might be external stimulation. So she will feel good, and oxytocin release will come. And oxytocin is the hormone which is gonna start the labor. Okay, that is gonna make this uterus to create a contractions. So we need oxytocin, and oxytocin is gonna relax the cervix also, cervix internal os. So for the dilation of the internal os, we need oxytocin. So, and we will also advise our female to start having penetrative sex. We were not having penetrative sex during the pregnancy. Now she should start having penetrative sex, or when this oxytocin will open up the internal, it will stimulate the internal os of the cervix, but the sex is gonna stimulate the external os of the cervix, because this is the cervix, and cervix is having, and we are having this internal os and external os. So oxytocin will open up it, dilate it, and this sperm, when the sperm will be ejaculated here, sperm is having prostaglandins, some chemicals which has the ability to soften the mucus of the cervix. So it will activate the external os, and the mucus, the thick mucus which is present here, this sperm is gonna, the semen is gonna create a softening of that. It's gonna change the pH level of the vagina also, and it will stimulate the external os. And this touch also is going to stimulate the external os, and it will it's going to induce the labor. So both way, oxytocin from inside and semen from outside. So ejaculation is important inside the vagina during that particular time. This is a mechanical stimulation which is going to help her induce the labor. We'll advise our female to keep using even those kind of pumps, breast pump. So she can apply the breast pump and like pull the these nipples outwards with the breast pump. So that will also be, it will also stimulate the breast. Same way, she can apply some kind of vibrators or sex toys around that vulva also. So that will help her in relaxation, the pelvic floor, penile body, as well as good sensation, feel good sensation after the ejaculate, after this orgasm. So, and relax as well. Relaxation also is gonna happen. So this is important to induce the labor, and we will only advise that if she's crossing her time, gestational time is more than 38 weeks and 39 weeks, and the labor hasn't started, then we can induce the labor by giving her these guidelines. Keep stimulating her external sexual organs, have masturbations, use vibrators, use breast pumps, or have sex. Make her practice following with focused mind. Relax her body, especially glutes and thighs. We have to tell her that whenever you will go for a labor, your glutes should be relaxed, your thigh should be relaxed. You have to always take a deep breath in, okay? Will put the pressure downwards and will help in opening up the vagina. And you have to give your level best to give the entry to your baby. So what is true labor and what is for labor. We will also give her a guideline about that. This is what we will understand tomorrow. Labor. We will understand labor tomorrow. Today, in today's session, we understood preparation for the labor. Okay, I hope that you get some clarity how, as a physical therapist, we are going to help our female into 9th month and going to create the perineal relaxation. Yeah, girls. So I'm stopping my session here. Tomorrow we'll understand labor.